everyone. My name is Okta. I'm from Subrameter. So before I begin, I would like to thank Knowledge Sector Initiative who have provide funds for our research, and also for the Faculty of Business and Economics of the University of Gadjah Mada as the organizer of this event. So today I would like to present a study about community health center response to the need of elderly with dementia in Yogyakarta Special Province, or DAY. Why we choose this topic? First of all, it's because study pertaining dementia is not yet prominent. There is still a few study regarding dementia, but what is exactly dementia? So dementia is a syndrome of declining memory, thoughts, and behavior that might interfere daily activities. And the risk of dementia is increasing with age, which put elderly are at risk of developing dementia. And other factors such as being female, less educated, physically inactive, previously had a stroke, hypertension, and diabetes also increases the risk of developing dementia. Then how about Indonesian elderly population? The Indonesian elderly population is dominated by female with low education and mostly had stroke, diabetes, and heart disease. So by looking at these statistics, we know that the elderly population in Indonesia is at risk of developing dementia. As I said earlier, that the study about dementia is still a few. Mostly the study is focusing on dementia prevalence and also factors associated with dementia. So dementia prevalence in the DAY was 20.1 based on a study in 2013, if I'm not mistaken. So again, because study and policies regarding dementia in healthcare facilities are not yet prominent, that makes us conduct this study. So the objectives of our study is to explore the response of community health centers or puskesmas in the DAY in relation to dementia cases among elderly in their community. And the second one, to explore factors associated with knowledge on memory loss as one of dementia sign. Then how do we conduct our study? So this is a cross-sectional study. We collected data on January to February 2021, so this year. So we interviewed all of puskesmas in the DAY, in total 121 puskesmas. So we interviewed head of puskesmas and or elderly program manager by phone because we're still in the pandemic situation. So we want to lower human contact to reduce the risk of contracting COVID-19. So the interview was assisted by Katie, a computer-assisted telephone interview. So we have 5 variables in interest. First, knowledge on 10 dementia symptoms. Second, participation on dementia prevention and care training. Third, whether puskesmas treated elderly patient with dementia. Next one is screening and coverage, and also reason of coverage achievement. So these are 10 dementia symptoms. First, memory loss. We have disorientation, misplacing things, poor judgment, withdrawal from social activity, and changes in mood and behavior. So dementia is not only about forgetting things, but it also influence your behavior and also mood. So we use logistic regression. Our independent variable was knowledge on memory loss, and our dependent variables were gender, age, puskesmas strata, cognitive screening, and also dementia training. So puskesmas strata here is different from puskesmas accreditation. So the Ministry of Health, they have policy called elderly friendly community health center, or a puskesmas santun lansia. So those puskesmas who are assigned as puskesmas santun lansia, they have 3 different stratum. So at the bottom level is Pratama, mid is Madhya, and the highest one is Paripurna. So let's see the result. So the result on knowledge on 10 dementia symptoms among puskesmas staff is low. So it ranged from 16 to 37%. And memory loss was considered as a sign of dementia by 79% of respondents. Why we choose memory loss is because memory loss is a typical sign of dementia in the early onset of dementia. So we thought that this low knowledge on 10 dementia symptoms could be related to training. So only 42% of Puskesmas staff had received training on dementia prevention and care training, which means that more than 50% of Puskesmas staff had not yet received training. So if we look at the percentage of Puskesmas treated elderly dementia patients, only 36 Puskesmas in the DIY treated elderly with dementia. This could mean two things. First, dementia is considered as a part of normal aging. And the second one is low screening. So which means there are less elderly get screened. So this is the result on cognitive screening and coverage in Puskesmas. So the Ministry of Health required all Puskesmas to screen their elderly, particularly in cognitive screening. They can use either IMT or MMSE. So IMT consists of 10 simple questions, while the MMSE consists of more complex questions, which also includes memory call. So the results show that the Puskesmas they conduct AMT screening is 64%, while the Puskesmas they conduct cognitive screening using MMSE is 27%. These numbers show a low cognitive screening because the instrument is already there, it's available, but there are some Puskesmas that had not yet conduct screening. So next one is the more Puskesmas use AMT than MMSE, again, because AMT only consists of 10 simple questions than MMSE. So it's suitable in primary care setting than the MMSE, because MMSE required more time and more caution in interpreting the score. And for both instruments, it showed low screening coverage. It's about 30%. So we examine the reason why the screening coverage in Puskesmas were as such. And we have highlighted 3 major factors. First is limited resources. Second one, lack of public knowledge, and also lack access to facility. The limited resources here is reversed to human resources. We might already know that the human resources in Puskesmas is very limited. And human resources is related to the ability to provide care, right? So with the low number of Puskesmas staff, they have a difficulty to conduct screening. And in this particular case, the Puskesmas staff who provide elderly care, they also have to do other health programs such as maternal health and also children under 5 health program. So they also face a problem in time as well. And then the second one, lack of public knowledge, it refers to the family and also caregivers of the elderly, where they probably have lack knowledge on dementia. So they think that elderly in their family, for example, if they behave oddly or starting to forget things, they think, okay, it's normal for them to have such symptom or such behavior because it's normal, it's part of their aging process. So, and the last one is lack of access to facility. It means that the elderly only get screened when they visit Puskesmas or health facility. Meanwhile, the behavior of Indonesian people, they only visit Puskesmas or health facility if the symptom is persistent. And for the elderly, this is based on the study in South Sulawesi. Elderly only went to seek help, professional help, only if their symptom or their health constraint is disturbing their activities. So this 3 combination is influencing the low coverage of cognitive screening in Puskesmas. So these are the bivariate data of knowledge on memory loss as one of dementia symptoms. As I mentioned earlier, we examine sex, age, Puskesmas strata, cognitive screening and also receiving dementia training. So our results show that the respondents who were male, more than 30 years old, and received dementia training had more knowledge that memory loss is one of dementia sign. And then Puskesmas with Stantun Lansia Streras Madhyana Paripurna, the higher one, the mid and the highest, and Health AMT screening had more knowledge that memory loss is one of dementia symptom. So the factors associated with knowledge on memory loss as one of dementia symptom. Here, we found that that respondents who participated in dementia training were 2.7 times more likely to acknowledge memory loss as one of dementia symptom. This finding highlight the importance of dementia training to provide appropriate care and treatment to those in need. So we conclude that Puskesmas response is low to the growing cases of dementia among elderly. Puskesmas staff have a low knowledge on dementia symptom because of lack of training, dementia training. Puskesmas also have low cognitive screening and coverage. And then participated in dementia training is more likely to recognize memory loss as one of a dementia symptom. In general, training on dementia prevention and care is crucially needed by Puskesmas staff. This is also appear in other studies in Australia and other countries where the result is similar, particularly in low knowledge on dementia symptom by the care providers. So they recommend training to improve the identification of dementia symptom among elderly, and also to increase confidence in using the screening instrument. And lastly, dementia care should be highlighted as one of health program priority. So actually, Indonesia have a national dementia strategy enacted in 2016, but the result or the progress is not yet prominent. The Ministry of
Ms. Dwi.
Okay, so the Ministry of Health already delivered the progress about this national dementia strategy, but again, we have not looked the progress in Puskesmas. So this is just several references, and this is the end of my presentation. Thank you.
Okay, thank you, Ms. Dwi. Okay, let's start with the question and answers. Okay, are there any questions about Ms. Dwi's presentation? Okay, I'm just while waiting question from participants, I just have one clarification question. In the slide, in the method slide, is when you write independent variable as the knowledge of, I don't know if it's real, is not correctly written, or can you show?
Okay, hang on. This one?
Yeah, for the logistic regression, it is written that independent variable is knowledge on memory loss, while dependent variable is gender. Is it the right, or is it like? I thought that the knowledge of on memory loss is the outcome variable or dependent variable. If gender is dependent variable, this means if the gender is dependent variable, it means that knowledge predict the gender. I think.
Oh, okay. Yeah, I think I misplaced this. Yeah, yeah.
Okay.
Yeah, thank you.
Yeah. Okay. So I'm just I want to ask about the question when you ask about knowledge about dementia. That means that the enumerator, the survey, asks each of the sign of the dementia, or can you like explain more about how?
Okay. Yeah. We actually asked those 10 symptoms to the respondent. So not only memory loss, but also because I have a slide talking about knowledge on 10 dementia symptoms. So we asked those 10 questions to the respondent.
Okay. I mean, why do you decide like only memory loss? Do you think that if we like create some kind of index or rating, which one is better for about?
Okay. Yeah, we actually haven't. Well, we choose memory loss because that's the typical sign of developing dementia, as the which usually appear at the early onset of dementia. So we want to look at those symptoms because many people think that memory loss is just part of normal aging, which is not. And there is a study that say that very slight change in the cognitive ability is related to dementia, developing dementia. So we want to spreading the information that memory loss is not part of normal aging. Then people have to start to think that if they see their elderly starting to forget things, they might have to take their elderly to get screened to the physician, probably. Yeah.
Yeah. I'm just thinking that if you, I mean, you might want to compare about whether you run the models individually for each each question, or just or you create like some kind of like the knowledge rate, the rate of the knowledge on dementia that capture all knowledge. That's only like my 2 cents of thought.
Yeah. I know. We haven't looked at those other symptoms, but we plan to compare it with the changes in mood and behavior, because when dementia is starting to progress, the worst symptom that can appear is changing in mood and behavior. But thank you for highlighting this. I think we need also to compare other symptoms as well. Thank you.
Okay, thank you. Are there any questions from the participant about this presentation? I think it's very, very important and interesting topic, because about the elderly health is still overlooked in Indonesia.
Sir, I think Mr. Novat has raised.
Okay, yeah. Mr. Novat, go ahead if you want to raise the question.
Yeah, I'm Pugo from Pusat Kapemak, FK UGM. This is an interesting topic, especially we are not, Indonesia is not that maybe in the developed countries like Europe and Western countries, they are already thinking about it. Even now, maybe in Journal Health Economics, most of them is about the aging and seniors. But for Indonesia and developing countries, this is one of the not get many attentions. My question is related to the design. I mean, maybe some of the basic questions is how Indonesia, how did the respondents is it how dementia in Indonesia they call it can we say it as a pikun or
yeah I know. In general, I mean, people might have known as pikun, right? But pikun is only
the one part of it.
Yeah, only one part. It's only related to memory loss. But again, dementia is not only memory loss. As I mentioned in my slides before, it's 10. There are 10 symptoms of dementia. But again, the Indonesian people, they might not know. They have like a low knowledge about dementia. So
yeah. And then this is interesting because how you design the study. Can I look the summary statistic again?
Okay. Hang on. This one?
Oh yeah. Okay. So. Okay. Yeah. That's the one that I interesting thing is how then it can be is your respondent coming to the Puskesmas, or you coming to directly to their home, or the first. The second, is it if the Puskesmas have providing service for the for this dementia program, is it also, I mean, they have to coming to the home? That I just imagine that the elderly cannot go to the Puskesmas very often.
Yeah. So first, your question about data collection, right? So
yeah.
As I mentioned earlier, we conduct data collection by phone interview. So we call them. So before we conduct the data collection, we obtain the telephone number from the district health office. And then in cases where the district health office cannot provide telephone number, we came to the Puskesmas and we meet with head of the Puskesmas to ask for permission and also the telephone number of the both head of Puskesmas and also the elderly program manager. And the second one, it's about whether elderly coming to the Puskesmas or is it Puskesmas staff who coming to the elderly, right? So mostly, if you look at the behavior of Indonesian people looking health-seeking behavior, as I mentioned before, they only visit Puskesmas when the symptom is persistent or if the symptom or health complaint is disturbing their activities. So I think there is two way for them to access the health services. First, they came to the health facility, and second one, well, Puskesmas have health home care program, right? So it should also be their means to screen the elderly. So for those who cannot go to the Puskesmas, the Puskesmas staff will go to the home of the elderly. And other thing is Puskesmas also have Posyandu. So they could also get screened in the Posyandu. But again, in our, actually our study consists of three different topics: Puskesmas, Posyandu, and also the elderly itself. So in our Posyandu study, it showed that the percentage of screening is also low. I hope it's answering your question.
Thank you.
Okay, thank you. I think we need to move to the next presenters. Thank you, Ms. Dwi Oktarina, for the presentation. Let's move to Ms. Radia Umaro for her presentation in health-seeking behavior among elderly persons. Okay, Ms. Radia.
Right. So, may I start the presentation? Assalamualaikum warahmatullahi wabarakatuh. Good morning, good afternoon, everybody. My name is Rodeh Umara and I am from Survey Matter. Today I would like to present our study about health-seeking behavior among older persons during COVID-19 pandemic, a community-based study in Indonesia. First, I would like to tell why this topic is needed to be discussed. So as we know that for the last 2 years, there has been a change in and around the world due to a massive spread of coronavirus disease, or as we call as COVID-19, which emerged across the world after it was first discovered in Wuhan, China in late 2019. So far, the COVID-19 disease has infected all people in all age group, but it has put the risk for severe illness with the virus increases with age and older persons at the higher risk. The same situation occur in Indonesia, where with the death rate is higher for older people aged 60 and years and older, with 49% of fatal cases are in this group. The higher risk also found in those who have chronic comorbidity. So that's why the screening of the COVID-19 symptoms must be carried immediately to inhibit the spreading of the virus, especially in groups that are susceptible to infection, such as the older person and people with chronic comorbidities. However, there are some obstacles during the screening because there are stigma and negative responses related to COVID-19. And it has caused the drop of number of visits of patients in the healthcare services. But avoid to seek treatment at healthcare services can increase the risk in undiagnosed COVID-19 and can worsen the comorbidities. And when it left to get treated, it might result in increased mortality. So our study objective here is we aim to explore how COVID-19 pandemic changed health-seeking behavior among older persons in community. We also try to examine the determinant of the health-seeking behavior. In the study, we used the data from a studi lanjut usia berbasis komunitas. The data conducted by Survey Matter collaborated with Knowledge Sector Initiative Interprovince. There are Bali and Special Region in Jakarta. Between December 2020 and March 2021, we used the PON survey technique to collect the data. And from the survey, we successfully interviewed 12 and 40 respondents, while the rest of the respondents had lost to follow up. And the strategy that we used to analyze the health-seeking behavior among the respondents, we used the questionnaire which asks the preferable place visited when they felt unwell in the period before the pandemic, or we coded as P1, and during the COVID-19 pandemic, or P2. So there are 8 alternative answers that the respondent can choose. First is hospital, and then clinic, and then primary healthcare center or puskesmas, a private, older person in the private healthcare, or posyandu lanjut usia, and then pharmacy, other places, and even not take any treatment at all. And whether we categorize the first 5 this a alternative answer into healthcare services, while the other is not healthcare services. Later, we classified the option picked by the respondents into 4 patterns of respondents' health-seeking behavior. So category 1 is if the respondent always seek treatment at healthcare services both before pandemic and during pandemic. And category 2, if the respondent shift in preference to avoid visiting healthcare services during the pandemic. Category 2 is opposite from the category 2, and then the last one is if respondent did not visit healthcare services both before and during the pandemic. So in this case, the respondent just to decide take alternative treatment or buy or medicine, or even not take any treatment whatsoever. And to do the examination or analysis, we use the descriptive analysis and employ the logistic regression as a program model. So in these findings in this study, we can look how health-seeking preference changed by respondents before and during pandemic, as depicted in figure 1. As you can see here, and then there are blue bar and red bar. Blue bar is for before pandemic, and red bar is during pandemic. So the result revealed that before the pandemic, primary healthcare center or puskesmas is the most healthcare services visited by the respondent, but during the pandemic, the visit of the healthcare services, either in hospital or clinic or puskesmas or private or posyandu, the percentage is dropped. But during the COVID pandemic, it approximated by those who decide not to take any treatment whatsoever, and the improvement is quite high, from 9% to 38%. And in general, there has been about 36 decline in older people with healthcare services during the pandemic. You can hear there are drop. And in line with it, there are increase in the percentage of the respondent who buy on their medicine at pharmacy or take other alternative treatment and not take any treatment at all. But from the 51% of this is predominated by this, the 38% from those who did not take any treatment. So we looked at the type of self-seeking behavior among other persons. That's on our previous slides. So the results reported that fortunately almost half of the respondents reported overseek treatment, seek medical treatment at healthcare services, but there are 38% of the respondents avoid to visit the healthcare services when they are sick during the pandemic. But there are 12% of the respondents who did not take any treatment at all, both in before and during the pandemic. So in this group, they are choose to use another alternative medical treatment. So the decline of number of visits of the respondent to the healthcare services can happen for several reasons. And in the study, we also try to ask the respondent what are the problems experienced by the older person when getting health services before and during the pandemic. So from figure 3A and figure 3B here, we can see that before pandemic, the most common problem faced by the older person was a long queue when getting healthcare services. But during the pandemic, it turned out that worried or afraid or scared has become the biggest problem experienced by the older person, with sharply increased from 1.4% to 34%. So many respondents stated or reported that they are scared or afraid to get infected by the virus by the staff or other patient when they visit healthcare services. And they also scared being diagnosed with COVID-19, so they avoid to visit the healthcare services. And then this is the result of multivariate logistic regression. So we have the 4 dependent variable. Dependent variable is the pattern of healthcare seeking behavior among the respondents. We also have set of individual characteristics to be determinant of the healthcare seeking behavior. And from the result, it turned out that gender, education, health status, worried or afraid of COVID-19, it's become a significant predictor to the pattern of health seeking behavior of the respondent. We first talk the significant factor first is gender. So we can here see that female older persons were more likely absent to seek medical treatment only during the pandemic, while the male respondent were more likely not visit healthcare services in both periods. So this result in line with previous studies, and they also confirmed that males usually feel that they are healthy and have tendency not to tell about their condition to their children and family, so that they tend to avoid to seek this medical treatment. Later, we have education. So it's turned out that other people who have education level at university were more likely to seek treatment for the current illness, either in pre-pandemic or during the pandemic. And they also have negative assertion with category 2, means that those people who that those people relatively always visit healthcare services rather than to buy their own medicine at pharmacy or take other alternative medical treatment. And in terms of health status, those who claim healthy at the time of the survey and having less than two comorbidities were more probably to skip care treatment during the pandemic. So this result is actually good because it's according with the statement of the government, the Ministry of Health, that they have to postpone routine health checkup except in emergency cases. And the last, we have the worried or afraid of COVID-19. So it is become a positive predictor for the other person to shift their health seeking behavior from visit healthcare in pre-pandemic to skip their treatment during the pandemic. So from the result, we can conclude that it is true the COVID-19 pandemic has impacted the health seeking behavior among older persons in Indonesia, and there was a significant decrease in older person visit healthcare services from 65% to 49%, with large for those who decide to not take any treatment at all for about 38%. And the pattern of this health-seeking behavior among the respondents predominated by those who always seek medical treatment, and followed by avoiding to continue visit healthcare services during the pandemic. But there are also who have kept not to take any treatment at all both before during pandemic. So it's also revealed that PA and female having higher education level and low level of health increase the probability to seek medical treatment at healthcare services during COVID-19 pandemic. But feeling worried or afraid or scared reduces the probability of the other person having their health checked properly at the healthcare services. So that from the result, it can also be concluded that so far, the older person in community in Indonesia have implemented the recommendations set by the government to reduce the visit to health services except in emergency cases. But however, the delay in treatment must be considered and important to be evaluated, especially if the older person have comorbidities and non-communicable disease. As what other country did, we can also use it. We can propose the telephone consultation for the other patients.
1 minute, Ms. Radia.
So that other person can keep check their health regularly, and also we can provide village level care agents to monitor the older person health condition in the village level. The role of the society is important in this case to protect the older person as a vulnerable group, so that we can assure that no one left behind in this pandemic situation. So that's the end of my presentation. Thank you.
Okay, thank you, Ms. Rodia. Let's begin with the question and answers. Please, if you have question about the presentation, you may ask. There's a question from Pak Budi. Pak Budi, go ahead.
Thank you very much. First of all, congratulations with the data set. I think the dataset is really valuable. However, if I would like to give some suggestion, the problem with those correlation that you and your team working on seem that the causal direction is not that clear. So, for example, whether feeling worry, so that then actually making the older people not visiting health center, or on the other way, that because they're not visiting health center, they feel worry. So the direction is not clear, and a lot of the variable that you're using having this problem. So you might want to think to consider something that in your right hand set variable, something that is really exogenous. So for example, if you have the data, for example, number of cases in a village. Now that number of cases, number of COVID cases in a village is exogenous to the behavior of the old. Then the direction of study is clear. So if you were able to get some of this kind of data, particularly indicator at the village level, and you then link that to the individual behavior, which your data is very rich, then that probably, I think it will be much stronger. So that is my suggestion.
I think this is just suggestion. Yes, Pak Budi, not question. Thank you for your suggestion. Yeah, we haven't included the age level of the behavior of the respondent. Yeah, we only use what is on the data survey, not included from the other data. So, but it's a good suggestion for us to improve our research. Thank you.
Okay, thank you, Pak Budi. Any other question? Okay, while waiting for other question, I also have some probably comments, not entirely question. Yeah, I mean, I want to build on what Pak Budi said, that there is probably some factor also affecting people avoiding to visit healthcare services. I mean, I think some anecdotal evidence says that the side effect of being locked down during the pandemic is that people are more engaged in healthier behaviors. They clean hands regularly, eat better, and so on. So probably one sense, because they stay at home, and then they tend to engage in a more healthy behavior, they are less likely to get to be sick. So that's why one of the problem. And I'm just curious if you include a question of variable if the respondent develop some kind of chronic condition during the pandemic, because if you feel you have the chronic health condition, you cannot avoid to get health treatment. For example, cancers or diabetic and so on. What do you comment on that?
So actually, I haven't even think about the side effect. So this is a good suggestion. So, but in the second question, for the older person who have a chronic comorbidities, we also have the result from the logistic regression. The result implies that there are significant association, positive significant association between them who have more than 2 comorbidities and visiting the healthcare center. So it is in line with your statement that those who have a chronic comorbidities have to regularly check up or regularly get examined in healthcare services. Yes, sir.
Okay, so yeah, I think a chronic condition is like one important predictors to force people to get health treatments. Okay.
Yeah, and that's why I said earlier that the result is quite good because those who have less comorbidities, they tend to less to visit the healthcare services, but those who have more chronic comorbidities, they always seek the treatment at medical services rather than to buy their or medicine at pharmacy or take other alternative treatment.
Okay, thank you. Any other question? No questions? Okay, if there is no questions, let's move to the next presentation from Mr. Novat Pugasambodo. Okay, time and place is yours now.
Okay, let me try to wait. Share my screen. Can you see now?
Yes.
Okay. Thank you, Pak Dinantera, for the time, for the opportunity. First of all, my name is Novat Pugasambodo. You can call me Pugo. I'm from Research Associate at the Pusat KPMAG, KKMK UGM. Is for the Center for the Financing and Assurance Management. Today, I would like to present one of my paper on Puskesmas financing. The big topic is the Puskesmas financing. The DOS corporatization, or we call it Badan Layanan Umum, improve primary care provider performance. Evidence from community health centers. Okay. Yeah. Okay. As we know, primary care is this is essential for our healthcare systems. Maybe all of the topics now is we talk about the Puskesmas because they are the gatekeeper before the patients goes to the hospital. So that's why it is essential that Puskesmas providing at least the minimum service standard. But we know that in Indonesia, it's only like only 53% of them that can achieve the minimum standard. Even another research shows that other research report that for primary care can handle 144 diagnosed. There's only a few of them only, if I'm not mistaken, for 1,400 of them can handle that the full. That should be the GPs that can handle the cases. So it's very limited. There are a lot, but some of them is not capable. So they also have problems in terms of financings. Puskesmas is under the district health office. That should be, some of them, the staff is PNS, this the local government officials, and the financing should be planned by at the beginning of the year, and then reporting, and then the logistics should be reported to the district health office. So because of the GKN, or National Health Insurance, there are funding from the capitations goes to the district health office, and then dispersed to the Puskesmas. And now they can disperse to the directly to the Puskesmas. But if there are some of the leftover or they are not used, so they can the capitation budget goes to the district health office, and that some of them is become corruptors prey. So corruptors looking for that, and then some of these, if I'm not mistaken, is one of the districts in East Java affected by the captured by the KPK for these for the corruption of the capitation funding. So they also have left almost 3 trillion of rupiah that's is not dispersed. So undispersed funding, it means that some of them the service is not goes to the public. The solutions, it is not new actually. The BLU is corporatization is the concept is back to 2012, if I'm not mistaken. But now, because of the GKN, they will some of the local governments encouraged to take this, especially for districts, to implement the BLU for this put their Puskesmas. So in definitions, basically same. Is the BLU is the working unit under the local governments, but they have a key is the efficiency and productivity. Keyword is efficiency and productivity. This is the one that the aim of the BLU. How they do that? So the BLU is the idea is how to make the Puskesmas getting more autonomous, getting more free on financial organization, financial management, and financial disbursement. So it's complicated, but actually the key is that the Puskesmas now can manage their funding. If they are still leftover or not undispersed spending, they can keep it, and then they can disperse it in the next year. Previously, this cannot be done, and they can go maybe rent some of the rent of the hall for example, for the wedding ceremony or sample, if they have hall, or they have something of rent or the park or something like that. Previously, they cannot be done. So the theory of change is they get the freedom and so on. Should be they can provide more service to the public. And one of the other freedom is that they can hire, but it's not government official, healthcare workers. They're under the BLU scheme. Okay, so the research objective is, does the BLU improve the service, Puskesmas service, including the performance? Why I am propose service quality? The first proposal is going to the Puskesmas service quality, but the data is not available. So now my research is focused on the utilizations. Most of them is about the utilization. So the research contribution, most of the blood research is of the corporatization is most of them only in one case, one district's case or several puskesmas only, and they are not using the impact evaluations framework, and most of them in a general literature, there most of them is using the hospital, not even in Indonesia, Maharani and 2015 and 2008, most of them is about the hospital, but not for the puskesmas. So I'm looking for the data. It's like looking the secondary data that I can use for these evaluations, but I end up only get the only 2, 3, 4, 5 that I use in my analysis. I get the treatment or BLUD status from the Ministry of Home Affairs or Kemendagri. But the BLUD is also unique because they are also Ministry of Finance that also handle this type of reform. There is a lot of outcome interest, but since they are limited, this should be the satisfactory and waiting time, but this because it's the data is not available, so I'm focused on most of them about the outpatient and patients. Okay, this is the treatment BLUD status. Actually, it's quite low in terms of the puskesmas. Only for 1400s that joining in the puskesmas level. The data comes from the Kemendagri of Ministry of Home Affairs asking for districts to how many puskesmas that you already BLUD that, and they only like 14% of the puskesmas in total. And if we talk about any district level, only like 47. Okay, from this treatment and BLUD status, and then I combine them with the Susanas, 2014 and 2018. Basically, I get the pooled cross section for the individual using the Susanas, but I also get the district panel aggregated from the Susanas 2014 to 2018. Okay, the next is using the PODES. PODES is more on availability because they are reported some of the availability of doctors and then available doctors, posyandu activities, and so on. And the Ministry of Health also have a nice data. It's about the costing and also for these healthcare workers. But my aim is to get the total sample, but actually I only get like the puskesmas level, only get 606 puskesmas in my analysis. This the data that I use is the variable that I use in this data is about the utilization. Okay, this is if we compare between the BLUD and non-BLUD, there are some of difference, but this is not the main problem with the DID setting. The DID setting is to be on the parallel trend assumption. But there are some of the difference, some of the negative difference between the BLUD and non-BLUD. That's also happened in the PODES in a level village level, and also for the puskesmas level. So I have a individual, I have a village, and I have a puskesmas level. And the results is not what I expect. It will be higher. Some of them positive in the skilled birth attendance in the puskesmas in the last 2 years. And the district's panel, actually that's what we expect, that outpatient in puskesmas, we only focus in puskesmas rate per 1,000 individuals. That's improve. But For the rest, it's not significant. In the village level, there also the increase of the posyandu with 2-month activity, the last 2 months. And yeah, the average outcome for in the level of Puskesmas using the third data sets.
2 minutes.
Okay, that's the increase of the some of the outpatient, inpatient, and home visit rate. Okay, and I found that outpatient rates is consistent with the Susuna's findings that increase per 100 individual. These studies, some of the have a limitation. First of all, in the Puskesmas level, sample is not available. The implementation of BLD status is self-selection. That's one of the problem. And the decision of the Puskesmas become BLD is a complicated. Should be agreement between Puskesmas Association and the local governments. So in conclusion, preliminary is not final. The blood improved outpatient rates in a Puskesmas and in 2 data sets that I mentioned before, and skilled birth attendance in Puskesmas in Susnas. And yeah, though the magnitude is relatively small, village in blood district has more posyandu activity compared to the controls. The blood is not significantly affect other outcomes such as inpatient, home visit, family planning, and so on. So the future research is we haven't checked. I haven't checked about the financial efficiency. It should be can be done if we have data on financial disbursement in every, especially for the health budget, and increasing number staff. Now is I'm going analysis in a on checking whether after blood the Puskesmas have more healthcare workers or not. Okay, I think that's my presentation. Thank you for your attention.
Thank you, Mas Novat Pugo. Yeah, Mas Pugo. Okay. Any question about the presentation?
Okay, sorry.
Yeah, while waiting for the question from the participants, I really like the topic of your research, and I think it is very important to improve the quality of health services in Indonesia. I'm just wondering, because you use the utilization rate as the outcome variables. That's, yeah, I mean, it's not the ideal outcome variables, but well, it's the only variable that we have right now, right? What do you think about if you? I didn't see if you control for example, possibilities that there is an local endemic or disease or something like that, because if there is a increase of the prevalence of any diseases, it will increase the utilization or the need to use the services from the primary care.
Yeah, thank you. About the suggestions, it's very interesting. Yeah, basically I'm trying with this is as an exercise of the data at first. Maybe I can expand to more, because if I would like to start with the basic one, see the outcome, and then I will add the controls ladders. But that's a good point, a valid point. Yeah, there is a data on this, especially if you use the Riscus DAS, if I'm not mistaken, with 2013 and 2018. But about the if there is a seasonality or maybe some of the something happening in the regions, it might increase the probability people coming to the Puskesmas. And that's a Riscus DAS. That might be one, but you know that asking Riscus DAS for districts is quite challenging. The second is maybe the other option is using the PODES. There's some of the information on the some information on the kejadian luar biasa, or what is it? Something in 2014 and 2018. They have a record of if there is this maybe natural disaster, for example. That's also can be included in the as a controls. Or also the Susunas also have information on the whether a lot of people are sick on that districts. So there are a lot of possibility. Then thank you of this input.
Yeah, another thing that I'm not. One of the concern is that you said that being a BOLD is self-selected, right? I mean, it's not exogenous, it's not random. So there's possibility. So one thing that you might consider is that thinking about what factors that may like some kind of like exogenous factors that may can be used for like some kind of like instrumental variable for the decision to transform the Puskesmas into a BLUJ. So right now I couldn't. I mean I cannot like give the concrete ideas for that.
Yeah. Thanks for the input. That's also what I'm thinking when I still looking for the way out of this, because these self-selection problems. Actually, in the report from the Puskesmas to the Ministry of Health, Ministry of Home Affairs, there I have recorded that the first problems is with the I have it in the slides, but the first problem in the Puskesmas do not join is about because they're status quo. They like the status quo and not do not want to reform, especially first because the administrative things they have to prepare for a lot of reports. The first, because the income is not sufficient. The third is the existing regulations from the regulations of in the local governments, because this should be an agreement between the district local governments and then and the Puskesmas Association. And the lack of support, if district health office is not supporting the Puskesmas, they will not go to the so it's, and also if the Puskesmas staff is limited, they are not going to the blood, and if the facilities is not there. So, but there are also some of the health facilities is even they have adequate facilities, but they don't want to, because they like the status quo and not going to the blood. But I think if the capitations goes apart, because now capitation is like 60% of the total revenue of the Puskesmas. If they are growing influence on how the funding of the how the Puskesmas funding goes, and then it's just a matter of time if they are now rely on the capitations, and we can make a scheme that they follow the rules. Like you know, the Puskesmas now have kapitasi berbasis kinerja or performance-based financings. If they can combine them, so it's one of the idea of make sure that Puskesmas improve their service. Yeah, another thing that the quality is rarely available. Actually, the quality is available in Ministry of Health data. They have a Risnakes, riset tenaga kesehatan, healthcare research. They have a waiting time from people coming to the waiting time when they register and get the service, how long they will wait, and satisfactions, exit survey, if we goes to the Puskesmas and then exit and then ask how about your satisfaction level or something like that. But I did that. I coming to the Balitbangkes, but I haven't. It's challenging to get that quality. So that's why I'm left out the quality data.
Okay. Yeah. Thank you. Any other question? Yeah, I'm very interested with this topic because my expertise is my PhD is in the one of the topic is in the urban health policies, and I also teach public finance in my department. So it's kind of I mean, this topic is very interesting for me.
Yeah, thank you.
Okay, are there any questions? Okay, we still have like 1 minute left. So if you don't have question, I got a message from the student assistant to ask you all to take a group photo. And so I think we can conclude our presentation, our session, this panelization. So I think before we close the session, there are some closing remarks that I notes during the presentation. So yeah, from the first presentation, we can see that from the supply side, providing access or providing care for elderly people, especially those who are with dementia, is still overlooked in Indonesian health service, and we need more progressive effort to address these issues. Shifting to the demand side for the second presentation, we see that there is a pandemic also one of the factor that changed how the elderly people how to get the health services, healthcare, and then the last also the last presentation we discuss about what is the potential of how we change the governance of at the primary care system that might help to improve the quality of healthcare services in Indonesia. So okay, that's some of the closing remarks that I make, and thank you for all the presentation on participation from the participants.